Hello, and welcome to Overreactive. I'm Dr. Rebecca Dunsmoor-su.
And I'm Dr. Amy Bodish, and we are your expert guides on the strange and often uncomfortable journey that is perimenopause.
I get to be so excited this time, not Amy, because I'm going to introduce someone who I've had the pleasure of hearing speak here in the Seattle area and know to be an excellent physician and who's going to help us understand all things sleep in perimenopause. Dr. Meredith Broderick, can you introduce yourself and tell us a little bit about where you come from and what you do?
Sure. Thank you for having me. Well, I'm a neurologist by training, and I have subspecialty training in both sleep medicine and behavioral sleep medicine, which is a little bit unique because usually behavioral sleep medicine experts are psychologists. I've created a little niche for myself here in Seattle. I have a solo practice, and I tend to see a lot of people who have complex cases where they really need a little bit of both the sleep medicine and the behavioral sleep medicine angle, but then also patients maybe with neurological disease.
Well, that's wonderful because boy, do we have a whole host of patients who need sleep medicine and behavioral sleep medicine.
Can you describe a little bit before we launch into this, the difference between behavioral sleep medicine and sleep medicine? Just really briefly, the difference between the two.
I think from a practical standpoint, sleep medicine is typically an MD, and they're going to have more of the sleep apnea screening, CPAP, doing the sleep lab interpretations. Whereas if we have a patient in sleep medicine that needs CBTI, cognitive behavioral therapy for insomnia, something like CPAP desensitization, something that's non-medication and non-procedural, we're going to refer to someone for behavioral sleep medicine, a psychologist, and they may also have other areas of expertise that are more kind of psychology related or behavioral related.
That's very cool that you do both. That's awesome. Thank you for that clarification. I appreciate it.
We invited Dr. Broderick on tonight because we promised you 3 episodes of Your Brain on Perimenopause. Mm-hmm. And this is episode 3, which is sleep, because sleep is a critically important topic. I don't know about you, Amy, but my patients are constantly telling me how disturbed their sleep is.
Oh, yes, my patients.
Yeah.
I.e.
our patients have disturbed sleep. Yeah.
I.e. not us. I'm not experiencing that.
Oh, yeah, right. This has massive downstream effects on everything. We did a whole episode on cognition and brain fog, but that's impacted by sleep. We did a whole episode on mood, but that's impacted by sleep. So I think the thing we hear the most commonly, and you probably do too, is, hey, doc, I'm exhausted. I can get to sleep just fine. And then at 2:00 in the morning, I wake up and my brain is wide awake and I cannot get back to sleep for hours. What's going on there? What is that? And what type of insomnia is that? And what's going on?
Basically, for the love of God, why is that happening? Just please.
There are different reasons why, and most often it's multifactorial. And I think that's one of the things that I try to educate when people come to see me, because I think people are thinking, oh, it's this one thing that I could just figure it out, then it wouldn't happen, right? And usually it's a combination of things. But the classic type of chronic insomnia that we think about that behavioral sleep medicine or cognitive behavioral therapy is trying to address is this notion, we call it conditioned arousal. So one of the metaphors that I tell my patients is, I took my 5-year-old to get her ears pierced, and they pierced the ears at the same time. And there's a reason why they do that, because if they pierce one and then do the other, they won't get the other one done. Because the child has learned and they experience the pain before it's happened.
Right.
So when someone's had this middle of the night awakening that may have started for one reason, maybe they had a stressful day, they have a big something the next day, they've experienced this painful or unpleasant, and becomes this anticipation about it. And so then there's kind of this awareness and anxiety, and you anticipate it. It becomes kind of a habit, a bad habit. And so the CBTI that we use for that, that's only one type of sleep maintenance insomnia, I would call that. That's one type. It's a condition type. I expect it to happen. And when it happens, oh, there it is. Here it is again. And there's sort of these patterns that unfold. So that's one reason. Sleep disordered breathing or sleep apnea can be, upper airway resistance. It can be mild sleep apnea. That's another extremely common, and women present very differently than men for sleep disordered breathing. They often present with insomnia rather than snoring or gasping,
Interesting.
especially women who are,
Oh,
not overweight.
I had a patient today with that who we got all kinds of things taken care of, hot flashes, night sweats, irritability, all better. Great. She's like, I feel like I'm sleeping better. She's like, but I'm just so fatigued. And I said, well, have you been to a sleep clinic? What's going on with that? She's like, well, I have mild sleep apnea, I guess, based on this test, but she's thin. She hasn't gained any weight. She doesn't snore. And I was like, I think we need to address that. Like the hormones aren't going to make that better. Like we have to treat your sleep apnea. And she was hesitant to do so, but she was like, okay, that makes a lot of sense after we talked through it. So that's so timely based on my conversation just a few hours ago.
Yeah, and I'm also really glad you brought up the fact that women don't necessarily snore like train cars, because I often fall into the pattern as a physician asking about that. Well, do you snore? Does your partner say you stop breathing? But oftentimes for women, it may be more subtle, right?
Yeah, definitely. It can be so subtle that it can seem like ADHD. It can seem like mild depressive symptoms. It can seem like high anxiety. That's one of the things where our nomenclature in sleep medicine is really problematic because people hear mild and they think it's not a big deal. But women, and especially like fairly healthy, not super overweight women, are going to have mild sleep apnea. It's not going to be moderate to severe just because of the way the nomenclature and the way that we classify things.
I'd love to hear a little bit more about that, because I think there's this mystery around sleep apnea. We have this vision of a 250-pound man who's snoring and then stops breathing for 5 minutes with a huge neck. But there are different things that diagnose sleep apnea, right? It's not just the snoring or the big pauses in breathing.
Yes. We think about different phenotypes of sleep disorder breathing. And so there are some people that their brains are very arousable. That could be because of anxiety. It could be because of a genetic trait. Could be because of stress, for many different reasons. And some people, their airway just isn't going to close to the point of a 3% desaturation or a full apnea. They're going to have these, what we call like micro arousals in their brainwave pattern. They're not coming to full consciousness, but towards the second half of the night, our sleep drive is a little lower. We're in REM sleep. We might have rolled to our back, and then we suddenly might wake up and we just don't have the gas to fall back to sleep because our sleep drive is lower and we've developed this conditioned habit of waking up. So it can also be two things. You can have a combination of sleep apnea woke me up, but now this more behavioral issue is what's keeping me from falling back to sleep.
And I think what's important about sort of talking, because I'll have patients say to me, I had a sleep study, but I only have mild sleep apnea, so it's not a problem. I'm like, well, but if you're having all of these micro arousals where maybe you're not fully waking up, maybe you're not like gasping for air, but if you're having this disrupted sleep pattern night after night after night, that is going to be exhausting. Like you are going to, I think, but please correct me if I'm wrong, I would assume that you would feel really crappy.
No, absolutely. And if you look at, cardiopulmonary coupling or different cardiovascular parameters, you'll also see the sympathetic nervous system is being affected. And that's one of the reasons why there's a very strong association with high blood pressure and developing atrial fibrillation and other things. But the severity of the sleep apnea does not correlate with the symptoms. So someone can have very, very mild or even just upper airway resistance and be very sleepy and have a lot of, brain fog and poor quality sleep. So that's why it's really important to, I think, have more awareness and to educate and say,
Yeah.
well, if we have these non-invasive options like CPAP that's covered by insurance, let's give it a 90-day run and see what happens. Or let's try something that you feel receptive to.
So I'm going to take Amy's other catchphrase, because I started this with being so excited, and now I'm going to say you've just blown my mind. Because I think that many of us in the perimenopause space who do perimenopausal medicine talk about anxiety being the issue waking people up. But I don't think necessarily I'm thinking of these women as possibly having this type of mild sleep apnea. And I just wonder to myself, how many of us are experiencing this and have no idea. And the other thing that sort of popped into my head as you were saying that, because you're talking about linking it to cardiopulmonary outcomes and long-term health, is that we talk a lot about women who have a lot of hot flashes as being at higher risk for cardiovascular outcomes, blood pressure issues, things like that. And I wonder if there could even be a link, because we know hot flashes are generated in the brain with disordered sleep, and hot flashes, we know hot flashes can cause disordered sleep. But on the other hand, could it possibly be that disordered sleep is making your hot flashes worse?
I think so.
All of these
Yeah.
things are interrelated up here in our brains.
Yeah, 100%. Sleep disordered breathing is autonomic instability, right?
Yeah.
You should not have sympathetic activation while you're asleep. It should be a time.
And hot flashes are also
Yes.
very much similarly. Oh, wow.
So to bring this down to my level of talking, so when we're talking about the sympathetic and the parasympathetic nerves, the parasympathetic nervous system is what takes over when we're in this restful sleep. So we're like fight or flight. So parasympathetic, we want to be in this calm state. But if our sympathetic nervous system is revved up, that is not what we want to be happening during sleep and rest phase. And so that can have an impact on, like we said, when we talk about our cardiovascular system or our cardiopulmonary system, we're talking about our heart and our lungs and our blood vessels. All of those things should be in a really restful, peaceful place while we're sleeping. We should not be revving up our blood pressure while we're sleeping. The whole point of sleep is for us to have a restorative time so that we can hit the ground running and feel refreshed in the morning. And when we have all this disrupted sleep, it can definitely, our body doesn't have that time to rejuvenate. And so it just is like a snowballing effect on itself. I might be making that up, but that's the way I sort of that's the way I think about it when I'm thinking about kind of what's happening with our different neurologic systems. And we shouldn't have to be thinking when we're sleeping. But if our brain is like, wait, am I fighting? Am I fleeing something, or can I like chill out and rest? And that's very distressing for our brain when we're supposed to be in our restorative sleep pattern.
Yes, absolutely.
And I also wonder, if you're in that pattern while you're sleeping, does it only get worse during the daytime?
Nothing is better during the day if you haven't slept. My God.
Well, it's interesting because when upper airway resistance syndrome, which is like the mildest form of sleep disorder breathing on the spectrum, there's snoring, and then UARS is what we call it, and then mild, moderate, severe. One of my mentors is the person who first reported it. The syndrome he reported was you would have like cold hands and cold feet was a very common manifestation. It's in a thin person because it is this like autonomic dysfunction type of. In sleep disordered breathing, there are people that are hyperarousable, meaning these changes in the thoracic pressure wake them up, or there are people that their airway is just collapsible, either anatomically small airway or just for whatever reason, the neurological control of the airway is more collapsible.
Oh, wow. We're I don't know. We've learned so much already.
I'm basically speechless. Thank you.
So one of the other questions I wanted to ask is that, we've talked a lot about this waking in the middle of the night, and that's a very common thing that we hear from perimenopausal women, but there are other kinds of insomnia, right? And can any of these become more common during the perimenopausal transition or early menopause?
Definitely. I mean, sleep disorder breathing definitely does. I think that also lifestyle changes happen. So people sometimes retire, sometimes people have kids leaving the house, and maybe they're not as restricted in keeping as much pressure on the sleep window. Sometimes they may drift the timing of their sleep just because their responsibilities change. People can have some kind of trigger, like let's say they have a surgery and they're not as active, and then they're, not moving around, they're not going outside. That can sort of trigger, there can be triggers that, I think those things are maybe more common. There's more stresses, as you get older, your life becomes more complex, you have more problems. I think those things can be triggers. Maybe you had cancer or your family member had cancer, and those things can be triggered.
That makes sense. I've definitely changed my sleep pattern as my children left the house.
Tell me you're getting more. I would like to hear about this.
Yeah, right. I'm menopausal, Amy. I don't sleep well.
Okay. Well, Okay, so this is as good as it's going to get for me. Like I'm
Well,
definitely on the downward slope. Okay, good to know. Good
well,
to know.
maybe when we get to the like, what do you do about it later, I'll learn some strategies and get better sleep.
So I have a patient who the other day, she's like, I've got one of those Aura rings, my Apple Watch, whatever. So I'm sleeping enough, but when I wake up, I just don't feel good. Do you think that's kind of maybe those like subclinical-ish sleep apnea, like where it's not quite obvious, or are there other types of sleep that maybe we don't actually wake up feeling as refreshed as we should?
I'm glad you asked that because I think a lot of people depend on these devices to tell them that they've gotten deep sleep or REM sleep or and that gives you this whole pattern. I'm not even sure how much we can trust it, but what does that mean? What do all those patterns mean?
We have a lot of data on this now. When I was at the conference this year, one of the experts was telling me there are like over 100,000 publications on it now. And
Wow.
yeah,
Okay.
and they're really just not that accurate,
Okay.
especially in the sleep staging. They're just not there yet.
They're looking at like heart rate and movement, right? That's the only data they get.
Yeah, and then if you're a person who moves a lot in your sleep, which can be completely normal, it will tell you sleep less, and you can be laying there completely still watching your phone and it thinks you're sleeping because you're not moving at all. Things like that happen. But to answer your question, the timing would be really important because someone can get like a normal amount of sleep and the timing could be off, meaning they're staying up later on the weekends or there's a lot of irregularity. There's also a whole set of conditions called hypersomnia. So, like narcolepsy is one of those where the manifestation can be, non-restorative sleep. There's like a few, different reasons. Obviously, there's some medical reasons, right? And then there are some people that are what we call long sleepers and they need more time, but we would want to screen someone like that for sleep disordered breathing. Sometimes if there's a lot of movement, different like limb movements that can disrupt the quality of sleep.
Like a restless leg syndrome kind of thing?
Yeah, like something called periodic limb movement disorder. And then, I would look at her medications and just see what are you taking and are you groggy? And then also just cracking into really trying to get her, like interrogating her about what are you actually feeling? Because sometimes people say they're tired, but they're not sleepy. It's something maybe more like depression, or those are the things we want to try to distinguish between like sleepiness and other symptoms. And we have some good questionnaires for that, but sometimes we do just test people and we do have ways to objectively test how sleepy people are.
Never thought about how one would test how sleepy you are.
What I'm hearing is that perhaps one of the co-hosts of this show should perhaps go to get a sleep study. Okay,
Yeah.
good.
All right.
All right.
Yeah.
Or both.
Or both. We talked a little bit about cardiovascular risk of poor sleep. But what are all the things that sleep does for us? Like we talked about it being restorative, but what does that actually mean? Like what is your brain getting out of sleep? What is your body getting out of sleep?
Yes, great question. There are many reasons, and some of them actually aren't as relevant anymore now that we live in modern times. I always tell people, people like to say, why do we sleep? But it's like, I think to me, it's, why do we sleep at night? And one of the reasons that we sleep all together in a consolidated period is it was a behavioral adaptation to nighttime, the solar cycle, because it's very energy expensive to be active when it's cold and it's not very helpful because we can't see very well. So as a way to protect ourselves. But during that time, our brain is cleansing itself. There's something called the glymphatic system. So it's sort of like the lymphatic system in the body. And it's cleansing all the waste products from during the day. I think that happens in our deep stage. Then the other things happen like memory consolidation and learning, emotional processing. And, in general, it's just this restorative process for the day-to-day activities so that we can, get up and do it all again.
Yeah. I never really thought about why we sleep at night. It's just the state of what we do. But, now that you say that, I'm thinking about my cat who sleeps day and night and all over the place in little bursts because he can see at night.
Right.
And he has fur.
Right.
Yeah, it's adaptive.
And there are small
Interesting.
rodents to hunt in the middle of the night.
Right. Interesting.
Yeah, but it's really important because all of these different sort of like circadian rhythm disorders that we see, there's this idea that in nature they don't really happen because electricity really disrupts all these circadian rhythms, whereas in nature you're so dependent on the solar cycle that you have to get everything done when the sun's up because there's nothing else to do and it's dangerous. And that's also why our core body temperature goes down. That's why we put the thermostat down when we go on vacation, is like, why produce all that heat if you're not going to use it? And we're planning to sleep, so why would you would take all the heat from your muscles, bring it to your core, and that's why we say, like, don't exercise at night, don't eat late, because you're delaying that whole process. Like, we tend to think of sleep as consciousness you leaving us, but it's actually more of a process. And that's why, like, these wind downs and things are so important, is because when you initiate the process, it sort of unfolds the way it was meant to in nature. And then you get your melatonin secretion, and then your blood volume moves from your extremities into your core, and then your temperature starts going down. And so this whole process unfolds the way it was meant to. And then it's more restorative and more, I know natural isn't always the best way, but.
Oh, but that's fascinating.
Mhm.
So, okay, so many things there. So what do you say to like shift workers, right? Who are working the graveyard shift and so they can't follow the natural cycle. I mean, and then on the weekends, like let's say, for example, they work 5 days in a row, they work nights, and then they have the weekend where they're not working nights, but now they're like trying to get back on the day schedule because that's when their family's up. Like, what? Whoa.
I know. And I'm thinking especially of those of us in medicine and obstetrics
Oh, God.
specifically, got 20 years of nights, days, 24s.
Right. Just fluctuating all over the place. That's why I'm exhausted. I'm going to blame it on that. So how do you counsel those patients? Like, what do we say to them?
Well, so I tell people, you have to think like you have a dangerous job. It has this inherent occupational risk. So if you think about like someone who's like a rock climber, they want to take certain precautions to mitigate the risk. So number one, we're going to be very aggressive about every other aspect of your health. And when we look at your sleep, we're very carefully going to try to figure out how can we optimize your sleep. And so a lot of this data actually comes from studying nurses. And one of the things you can do is try to at least keep some core part of the sleep consistent throughout the week. If there's a way scheduling wise to do that, in other words, just have it overlap at some point. Sometimes that's not possible because it's a parent and they have kids and they have other responsibilities. Sometimes it's just sort of encouraging the person, if possible, financially to work less, to maybe do this for a shorter amount of time in their life and to change it. Sometimes I see like retail workers that are working all these shifts and I say, like, you just need to like take a shift out. And if people are really having trouble, that sometimes they need a doctor's note to say, like, you need this accommodation, you need to be able to take naps at this time. Sometimes there are FDA medications, alerting medications, just to make sure people are safe.
Right. Because driving home or whatever, right? Yeah.
But, people who do this sort of night shift work, they are prone to things like metabolic dysfunction and gaining weight. And so, that's some of what I'll work with people. Now I'm putting on people on GLP-1s if they're overweight. And we think, just we're trying to mitigate anything that could be a downstream effect of this, because I think a lot of the research shows that it's one of the reasons really harmful is because of the inflammation that develops from, basically the sleep loss.
Yeah, that makes perfect sense. And you sort of brought up weight, and I wanted to ask you about weight and sleep because I think I counsel a lot of my patients that, there's a natural weight gain through the perimenopausal transition. Most women in their 40s and into their early 50s are going to gain 10 to 30 pounds. Then they start to try to manage that weight and lose that weight, but they're not sleeping. And if you're not sleeping, you're not going to be able to lose weight, are you?
No. And it's sort of a bi-directional relationship. Once you gain the weight, you're at risk for sleep apnea and metabolic dysfunction and other things. I was seeing someone this week who was saying they couldn't make it through the night without eating. And I just thought, well, that could be behavioral, like you've trained, but also, I'm wondering, are you having low glucose? Or I'm wondering if we need to do some lab work and maybe a CGM and see if that's what's triggering it.
Is there a fundamental effect on like our metabolic rate? I tell people it's a combination effect. I say, well, if you're not sleeping well, then you don't have the energy to exercise. You don't move your body as much. You crave starches. You crave sweets. And all those things are true. But does that lack of restorative sleep actually impact how we process calories?
Well, I think it affects the leptin and ghrelin. So it does make us want to eat sugary food and carb heavy food. And
you should see the number of Girl Scout cookies I could go through on an OB overnight shift.
Oh,
I can
and the pad thai that I ate that was single-handedly responsible for the 20-pound weight gain of residency. That was fun.
And before I let you finish that thought, you have to tell us what leptin and ghrelin are.
So these are hormones that regulate appetite and satiety. So ghrelin is a hunger hormone, and then leptin would be more like satiety. And so these hormones get out of balance so that we perceive we're going to be more hungry and want to eat more. And especially, I think the study's shown we're more prone to eating carbs and sugar.
Yes, I have called this the food-sleep continuum.
Yes.
And like when your sleep is terrible, you're going to eat more. And now I have the science to back it up, baby.
No, it's true. I mean, it's like, I don't need a study to show me that. Like, I think people have experienced that, right? It's like if you have a couple too many glasses of wine and you're like, oh, I just want to, in college, it's like eating pizza for breakfast. And
pizza for breakfast is pretty good though.
Yeah.
I gotta say, it's one of my favorites. Cold pizza for breakfast.
So good. We had a place that would deliver at 3 a.m. Pizza Central, $3 pizzas. It was amazing. Also responsible for the weight I put on in college. So, okay. So you mentioned sleep studies. So I have a couple questions about sleep studies. You mentioned something called a CGM earlier. What's a CGM? Is that a type of sleep study or is that?
No, a CGM is a continuous glucose monitor. And
yes. Okay.
It's basically something you stamp in your arm and you wear it for 2 weeks, and it can give you a general idea of what your blood glucose is. It's actually measuring the interstitial fluid, but it can give you an idea of trends. And I think it's become a little trendy, I think, in like the kind of wellness hacking space because
the longevity clinics are all over it.
Yeah, but it can be helpful. I mean, for people that are not necessarily even pre-diabetic or diabetic, your glucose can tell you how much insulin you're secreting to capture all that, even if you are still sensitive and responsive. But people will even notice things like, from that insulin surge, they feel tired, they want to take a nap. And people will notice that maybe they get even some lows when they're asleep. If they have a big meal at bedtime, because they can maybe overshoot a little bit on correcting for that. And it can encourage people to have evidence to say, I need to improve my nutrition to improve my sleep.
Yeah.
Yeah. So you don't know this about me. I'm diabetic and I've used CGMs off and on just to sort of monitor how I'm doing with managing that. And it's so enlightening sometimes because sometimes it's just, the foods you think are good for you just aren't. And it's different for everybody, I think. I tell my patients, I used to think that grape nuts were really healthy until I ate a bowl of grape nuts while wearing a CGM and my blood sugar hit 250. And then I realized they're all carbs and no fiber.
Yeah. I mean, I think most cereal is like that, isn't it?
Yeah.
Yeah.
But of course I was like, oh no, I'm being so virtuous. I eat grape nuts with no sugar. It's got to be healthy. Turns out no.
And a lot of people actually eat cereal before bed. I don't know if you hear that.
My God.
But people will say, I have a bowl of cereal, and it is like a big carb bomb.
I wake up shaking in the middle of the night.
Yeah.
Oh, yeah. No, the Vodish family, so my last name is Vodish, and our Vodish family trait, all the Vodishes love cereal, like are obsessed. And we all want to eat bowls of it before we go to bed. Like we're totally conditioned to do this. I now can't really have cereal in the house. Otherwise, I'm going to eat it.
It seems like such an innocuous thing to do too, right? But it can affect your sleep to have that.
Yeah. Oh, this is fascinating. My aunt's going to be listening to this. So Auntie Woo Woo, this is why you should not have that bowl of cereal before bed.
And I felt so virtuous too with my grape nuts while my husband was eating like sugar corn pops. And his blood sugar didn't go any higher than mine.
Should have just had the corn pops.
I know, seriously.
Okay, so let's get back to my question on sleep studies because people are like, I don't want a sleep study. I don't want to do that. I don't want to go to the clinic. That's going to be weird. how do you counsel folks through that so they're not so nervous about it?
Well, home sleep apnea testing is pretty much standard of care these days. I mean, it's been that way for a while, probably over 10 years because of insurance companies, insisting upon it. And I think that's one thing people don't know is there are higher quality sleep tests than others. Some of them are more sensitive, some of them are more user friendly. Some of the hospital systems I think that maybe don't catch up as soon as are using maybe more dated studies that have lower sensitivity. So, and the brand of it and the type of test can really vary a lot. So that's one thing I tell people to ask about. And different doctors will have different opinions about that, I think. But basically, with my patients, what I do is I mail it to them and they download an app. They put on a wristwatch, a finger cuff, and a chest sensor. They sleep with it overnight. It goes through their phone up to the cloud, and I give them the results the next
Wow.
day.
Wow.
And it's, really easy. And then we can have a follow up and go over it. And so, I can see my patient, screen them, and see them back within like a week's time. Very low test failure rate on the test I use. Sometimes if tests have a high test failure rate, they do like 3 nights or we'll do like more than one. But yeah, they become so nice. And Apple, I think, on their watch has a feature to kind of flag people if they're looking like they have more moderate to severe sleep apnea. I think the Samsung watch has something similar. So
Oh,
they'd be able
wow.
to catch like these more severe cases.
Which is cool. But for perimenopausal women, where it might be much more subtle, it might be the mild sleep apnea or just the upper airway obstruction, sort of pre-sleep apnea, so to speak. We might need to do one of these home tests because that's the way to really figure out, if this is really
What's
happening or
going on?
not. Your Aura Ring. So I think the take-home message for our listeners is that your Aura Ring and your Apple Watch might not be sensitive enough to pick it up for you because, shockingly, women are different than men. And as we've said many times, and if it's not moderate to severe, these devices might not be picking it up. But you can still feel really crummy with mild or even pre-sleep apnea. And so it's important if you are having that fatigue despite, treating your hot flashes and your night sweats and you're not laying awake at night. Like if we get to those things are where they need to be, like we should be looking into that for
Yeah.
sure. And I send a lot of my patients to sleep clinic. Like I'll still start like the menopausal hormone therapy or the perimenopausal hormone therapy, and that can help. But I send so many referrals to the sleep clinic. So I'm like, we just need to make sure there isn't an underlying issue going on here.
Yeah. And I'm suddenly feeling like I need to send more of them.
Mm-hmm.
One thing that for awareness of sleep disorders that we really have to work on is one, people are not conscious when they're asleep. So most of the time seems very surprising to people. And it also develops really slowly, something like sleep apnea or a lot of things, because we are so adaptable that I always tell people it's like the frog in the pot myth, if you've ever heard of that, where, if the water doesn't boil fast, it boils very slowly. The frog, doesn't jump out in time. And that's really how some of these sleep disorders happen. And that's really a challenge. And the job that I do is trying to convince people this is important. The same way it can be hard, how many times you have to tell someone, no, it's not white coat hypertension. You have high blood pressure. How many times does that happen to happen? And the person can't feel it at all. They can't feel how it's negatively affecting them, but if someone had a heart attack or a stroke, like they want to be on the medication right away, right? So
Right.
a little bit of is trying to really show people these fingerprints. And that's where the sleep study can really help is you can show like, look where your sleep architecture is fragmented. Look at, how you get these low oxygen in REM sleep. It could be kind of subtle. Look how much more you're snoring. And it can kind of make more sense for them. And then you can also start to tell them the story about some anatomic features they have or things that are happening in their mouth or nose or with their breathing. And it can click. Oh, yes, I see this now.
That makes perfect sense because we really don't know how good our sleep is. I mean, sometimes we know how bad our sleep is. But,
Yeah.
If we're mostly sleeping through the night, we may just not have a feel for how bad that is.
Yeah, what the quality is.
So now for the part of the episode that everyone's been waiting for. How the heck do we fix all this? Like, what are the strategies you use for different types of insomnia or sleep apnea? And as part of that question, can you talk a little bit about sleep medications and the good, the bad, and the ugly of those?
Well, in general, sleep medications for insomnia are just not great. I think they have a utility in the short term. So let's say someone lost their job or they're going through a divorce or something's going on that they're going to adapt to, then you might use a medication. There was actually this study that just came out in Cell where they were looking at people taking Ambien. And what they were showing is that this lymphatic system, this brain cleansing system we were talking about, is not working when you're taking Ambien as well. It's significantly decreased. And so even though you feel like you're sleeping, you're not getting the benefits of sleep. And if we look at something like CBTI, the cognitive behavioral therapy for insomnia, head to head with these medications, what we see is maybe they're close short term, but the effects are not sustained. And also, people don't like feeling dependent on medications. I think there's a stigma, or people feel something negative about it. But there is a time and a place. I mean, for restless legs, we use medications. There probably will be some sleep apnea medications available in the next 5 years. And there are times where, in jet lag or people who do shift work, sometimes, I think it's appropriate.
You mentioned CBTI. It's a favorite of Amy's and not mine.
Mhm.
We recommend it all the time. Can you describe a little bit about how CBTI works and what the research behind it is? And then we can talk about like resources for starting with CBTI.
So going a little bit back to how I was talking about, piercing the ears of a child, there's this conditioned arousal that develops. And the behavioral model for insomnia is that what causes insomnia is not what perpetuates it. What perpetuates it is there are these maladaptive behaviors that develop, and they're very common, and they vary a little bit in different people, but they're things like increasing time in bed. We call it casting a wide net. Thinking about sleep, trying to force sleep, devoting a lot of time to it, worrying about it, developing a lot of anxiety. And so, what CBTI is designed to do is to help draw the person's attention to that and help them develop more adaptive mechanisms. And so, there's 5 components of CBTI. One is sleep hygiene, which a lot of us have heard about. There's also something called stimulus control therapy, which is like Pavlov's dog, for those people who took Psych 101 and remember that. And then there's something called sleep restriction or reducing time in bed.
Oh, is that like sleep compression?
Sleep compression is a gentler form. So restriction, you might go from being in bed 9 hours down to like 6, whereas compression might be like slowly inching your way down closer to what you need. Then there's cognitive therapy, which is thinking at the thoughts and trying to reframe, develop healthier, more realistic thoughts about sleep. And then there's also like relaxation. There's a progression. And so I tell people, like when people come to see me, they're just like, please fix it now. I want to go from A to Z. And it really, CBTI happens in an average of 4 to 6 sessions. And first we try to improve the quality of the sleep. And then we try to lengthen the duration of sleep. And then third, we try to help, the person not relapse again, or to, if they have a bad night, to sort of get back on without having as much regression.
And my understanding of CBTI is it has excellent data behind it, right?
Yeah.
It's the thing that works the best.
It is. Yeah. It has very good data. But on the other hand, it is very time consuming. It's interesting because I even think people now with technology and stuff have sort of shorter attention spans. I think sometimes people have trouble with implementation and they need a little bit more objective input because people will come and say, I've done this CBTI program and it didn't work for me. And then when I really talk to them about what they're doing, they're really not implementing it correctly through no fault of their own, but just not really able to see how to connect the dots.
I saw a patient like that just this week who last time I spoke with her, I asked her to download the CBTI Coach app. And this, for those of you who don't know, there's a free app. It's called CBTI Coach. I think the VA made it for soldiers with PTSD, so everybody gets to have it free. It's not the most elegant app, but, the stuff is in there. I said, well, and she's like, I'm still not sleeping. Nothing's changed. I said, well, did you download the app? She's like, yeah, I downloaded it. I did for a couple days. Didn't seem to do anything. I'm like, oh no, this is not a couple days thing.
No. This is a solid 4 to 6 week effort. And when you get to the other side of it, you're going to reap the benefits, but you have to put the work in.
Well, but I think what she said, which I've heard so many times, is it's really hard to find, like she'd probably do better with someone who walks her through the process and working with someone one-on-one, but it's really hard to find.
Yeah. Yeah.
Yeah. As someone who can set the expectations, just like, when you do surgery on someone, you're like, okay, it's going to be really painful and then it's going to get better. And you kind of give them a timeline and here's where you're going to have an issue. And here's where, this is what you're going to do when that happens. I think also some people more than others, but don't appreciate sort of the therapeutic side of it, where the actual discussion and the conversation helps the person as well, like, be motivated and know what to do instead of sort of just overthinking it and becoming desperate. And there's this accountability piece too, I think, when you're working with someone.
No, I think that's really critical, actually. I did want to ask just quickly about CPAP, because we've talked a lot about sleep apnea and disordered sleep breathing. I think people are very afraid of the massive contraption on the head with the big loud generator. Has CPAP come into the 21st century?
It absolutely has. I mean, the masks are getting better and better. You can hold them in the palm of your hand. If you know what they look like, there's hundreds of them at the airport. You'll see. And it's interesting because a lot of people who are really nervous about it, they do so well. And they're like, it's so much easier than I thought. And what I tell people is, look, no one wants to wear a CPAP. I know that, but just give me like 90 days for you to try it. And if you feel like your life is better and it's paying you back dividends more than you invest, you're going to want to wear it. So it's covered by insurance. It's pretty much harmless. We may have to tinker with it. I tell people it's kind of like finding running shoes. Sometimes you have to go with it a couple times and then we change it out and then we, tinker with things. And so that follow-up care is also really important, because sometimes people will just do it like twice and then they just stop. Some people will say, can I just try it like once? And I'm like, no, if you want to try it, you really need to try it for like a month minimum, but ideally like 90 days. I always tell people I'm a sleep doctor. When I started wearing CPAP, I don't wear it anymore, but I did for a while until I had some other interventions. I said it took me 6 weeks to sleep through the night with it, and I'm an expert. So that just gives you kind of an idea of like, if you're able to like fall asleep with it and get like an hour, that's like where you're supposed to be.
It's a process. So don't give up is what you're saying. And there's various ways and different types of masks. And it's just like what I tell my patients with menopausal hormone therapy or perimenopausal therapy. I don't always get it right the first time. And so you have to come back, and it's the art of it. It's like you said, you have to tinker with it, and then you can get to the right place, and you have to do the work.
Yeah.
There's no easy fix. It didn't happen overnight, and you can't fix it overnight either.
Right.
Yeah.
Unfortunately.
I know, right? Why aren't there ever any easy fixes?
I know. We're not big on the easy fixes, Amy.
No.
We're going to find something we can do an episode on where we're like, you take this pill, all better.
All better.
Because we haven't found that one yet. But I'm glad you mentioned sort of 3 months, because I actually tell my patients who I'm starting on any kind of hormonal therapy, whether it's birth control or menopausal hormone therapy type medications, you have to give this 3 months. Your body, you'll have a honeymoon phase, then you'll have a dip, and then you have to give your body time to adjust. It has to learn that this is the new normal, and then we can assess how you feel. It sounds very similar with CPAP.
Yes.
Yeah, exactly.
All right.
Well, Dr. Broderick, thank you so much for coming on.
I learned so much.
I've learned so much. I'm sure our listeners are just going to be over the moon with all of this information, because it's really one of the main issues that people come in to talk to us about is their sleep.
Yeah.
Yeah.
And you may see me on your patient rolls in the next couple months.
I know.
Because I really get to that fixing the sleep thing.
I know. Can I do telehealth across state lines?
So I just have to, in full transparency, I am one of those people who downloaded the CBTI app and got like 3 days in. I'm like, oh, this is so much work.
Okay,
I'm too tired for this.
I'm too tired for it. Right. Yeah, exactly. Oh my gosh.
Just trying to be honest here.
Yes. But it could work fabulously for someone else.
I think if I'd given it a chance, it probably would have worked well for me.
Right.
I just, we're like everybody else. We have 7 billion things on our plates.
And apps aren't for everyone, right? Yeah. I mean, sometimes you just need more
Sometimes
than that.
Sometimes you need the accountability.
You need the IRL in real life situation. Yeah, for sure.
Thank you so much for coming. This just, we learned so much. We got so much out of this. And I'm just thrilled that we can bring this information to our audience.
And remember, You're not crazy. This is really happening.